Good morning, everyone. A warm welcome to all of you for today's webinar organized by the Society for Health Research and Innovation Academy. We truly appreciate your presence and commitment to continuing professional development. Before we begin, let me share a few important points regarding the webinar proceedings. The link to join the webinar will be available until 9:50 a.m. and access to the session will close promptly at 9:50 a.m. Late attendees will not be admitted beyond this time. By participating in this program, you can earn 1.5 CPD points and participants must remain until the end of the session to receive your CPD certificate because the Shri webinar series strictly adheres to NCPD guidelines. I hope you will keep your microphones and videos turned off throughout the session to ensure a smooth webinar experience to everyone. You can ask questions via the chat options at any time, and your queries will be addressed at the end of the session. If you have a very specific question to clarify, you can email us on officeshri13@gmail.com, the address shown in the screen now. After the webinar concludes, stay another few minutes and ensure you fill out the Google form provided in the chat box with post-assessment questions to receive your CPD certificate through email. This form must be submitted before 11 a.m. today. Please recheck your email address before submitting the feedback form at the end of the lecture, as many doctors missed their certificates due to providing incorrect email addresses. Kindly submitted the form correctly at the end of the webinar by 11 a.m. today. Please note that you will not be eligible to have the CPD certificate unless you follow the guidelines and answer the post-assessment questions. Moving on to the topic, management of traumatic brain injury, we have a well-versed resource person today with us, Dr. Eranda Sanjeeva, consultant in intensivist, neurotrauma unit, National Hospital of Sri Lanka, Colombo, with experience as an intensivist not only in Sri Lanka, but in United Kingdom as well. He is a member of multiple international societies, namely the General Medical Council, United Kingdom, Faculty of Intensive Care Medicine, United Kingdom, European Society of Intensive Care Medicine, and World Federation of Societies of Anesthesiologists. This will be an interesting session for everyone who needs to update their knowledge on management of traumatic brain injury. Over to you, Dr. Sanjeeva, to continue with this informative session on traumatic brain injury.
Thank you very much for your kind introduction. And I would like to thank these three organizers for providing me the opportunity to deliver this talk. So I'm going to discuss about the management of traumatic brain injuries. During my talk, I would go through these subtopics. And I know the audience is versatile. You all are working at different level. But during your career, most of you all would have experienced managing a patient with traumatic brain injury. So think about that patient, and during my talk, I will highlight the important points that you need to consider at a different level of our level of hospital care in order to managing the traumatic brain injured patient. So traumatic brain injury is a critical public and socio-economic problem because most of the time the breadwinners are affected. There are young, energetic people who are in the productive age group. So when they're affected, their dependents are also affected. Therefore, it's a critical public and socio-economic problem. We see most of them, they become either handicapped or they become permanent vegetative state, which is going to be a burden to their family and ultimately to our nation. So as you all can see, most of the time, the most common cause is road traffic accident. A country like us with low and middle income countries, due to poor infrastructure and most importantly, the road discipline is the major cause of traumatic brain injury leading to road traffic accidents. And you and me, we all use these public transport, so our lives are not safe. So we are at risk at any point to get traumatic brain injury due to our infrastructures and all our road disciplines. And apart from that, the workers who are working in the scaffolding and all, so in our country, it's hardly we see they are wearing their protective equipment. So that is another cause for traumatic brain injury. So coming with the definition, it's an external mechanical force leading to permanent or temporary impairment of either cognitive, physical, or psychomotor function. So invariably, it will lead to reduce the consciousness. The important is that even if you get a fractured or bangled limb, you can amputate and you can save the life. But when it comes to traumatic brain injury, it's different. So it's very much you affect your major organ, your consciousness, which is the most important thing. So it is quite important. So there are certain ways and means to classify traumatic brain injuries. So you can classify according to the severity, according to the occurrence and the anatomical location. So start with the classification according to the severity. This is the most important thing because it's very much important during the communication. If you are communicating from one hospital to another, if you say GCS is 5, that we know it's a severe traumatic brain injury and we need to arrange theater care as well as post-op intensive care. So it's very much important in communicating about traumatic brain injuries. And at the time of occurrence, so the primary brain injury, as medical professions, we can't do much. It has happened already. The injury that happened at the time of injury. So it's up to the local authorities and the police and the administrators and the non-communicable disease programs to arrange the preventive measures. As medical professions, what we can do is to prevent the secondary brain injuries, that the injuries that happens as a consequence of the primary injury. So these are the things that we can do. Systemically, they can have these hypoxia and hypotension and all the other metabolic problems. So as doctors, we are going to control these factors in order to get a proper outcome, a better outcome. So there are certain intracranial causes which act as secondary brain injuries. So the main fact is that the intracranial pressure that we need to control in order to prevent further damage. Apart from that, you have to control the seizures and prevent infections subsequently. If you classify according to the location, it could be focal brain injury or diffuse brain injury. It could be fracture, hemorrhage, contusion, and diffusely, it could be diffuse axonal injury, a contusion, or a contra-core injury. So a fracture, to get a fracture, there should be a significant force need to be applied. So it's a high velocity injury. So it could be open, it could be closed. So definitely this patient needs to be managed at a neurotrauma center. And like in our body, when we get bruising, the brain also gets bruising if there's a trauma. So we call it brain contusion. So with the contusion, the risk is the brain can get swelling. You must have experience when you get a bruise on your body, there will be a swelling. So likewise, you get swelling in the brain, which will increase the intracranial pressure. And most importantly, the hematomas. If you see here, you can get extradural bleeding. That is the bleeding between the dura mater and the skull. You know, we got 3 coverings, the dura mater, arachnoid mater, and the pia mater. So if you had a bleeding in between the dura and the bone, we call it extradural bleeding. So it appears like this. It's an lens shape because it's an arterial bleed which pushes the dura internally. It appears in the CT like the lens shape. So the importance of extradural hemorrhage is that these people, they get a time period called a lucid interval, where they come, they get the traumas. Most of the time it's like young people following sports event. They become unconscious. First, they come to your unit, but they get the consciousness again. Then they will be okay for some period of time. Then suddenly they will become unconscious. We call it the lucid interval. It's very much important if you are working in a primary care center that you need to identify. If you do not have CT facilities, so you need to monitor the patient, and they might get deteriorate with the time, though they are okay for a certain period of time. Normally, the extradural hemorrhage, the outcome is good. Once they evacuate, we can send them home without having disabilities, because it does not cause damage to the brain. In contrast, the subdural hematoma, where you get bleeding during the dura mater and the brain. So it's more or less venous bleeding. It appears like this in this image, and the CT, it goes like the sickle appearance, where you get the venous bleeding under the dura. The problem with that, there may be some element of brain damage with the subdural hematoma. So in contrast to extradural hematoma, they get sort of disabilities and prolonged ICU stay, and vulnerable to get a lot of complications. Apart from that, you can get subarachnoid hemorrhages, bleeding inside the brain in the subarachnoid space where the CSF flows, and the intraparenchymal hemorrhage. Those are the classification according to the injury pattern of hematoma. Apart from that, you can get diffuse brain injury. We call it diffuse because you don't see we see an obvious space occupying lesion. So in the clinical history, they come to you with low GCS, ECS less than 8. But when you do the CT, you don't see much bleeding or any other space occupying lesion inside. They can get a mild cerebral edema. So CT is insensitive, where you need MRI for the proper diagnosis. So we categorize them according to the grades. So the higher the grade, higher the mortality. So these patients, they stay longer in the ICU. They need tracheostomy, they need PEG, but mind you, they will recover. Some people we have seen they recover even after 6 months of the injury. So we need to continue their supportive care. So importantly, this intracranial pressure, we all have learned during our medical school days, the more or less more famous Monroe-Kelly doctrine. So the intracranial pressure is the pressure of fluid and tissues within the skull. As you all know, the brain is within a rigid skull with cerebrospinal fluid and blood. So one of component or compartment, if increased by its volume, one of the other compartments should leave the brain to provide the space for the expanding proportion to maintain the normal intracranial pressure. That is explained from the Monroe-Kelly doctrine. So as you will see, if you get the 80% brain, 10% fluid. So if you get, you'll say if you get a trauma to your brain and the brain matters expand likewise. So to accommodate that, the CSF should move from the cranial portion to the spinal canal. At the same time, the production will be less by the choroid plexus. And the blood flow again moves, the venous blood moves out of the brain, and brain volume will be increased. So still the intracranial pressure is normal. Once the intracranial pressure exceeds 20 millimeters of mercury, we call it intracranial hypertension, where it will reduce the arterial blood flow, leading to brain ischemia. That is the simple explanation of rising intracranial pressure according to the Monroe-Kelly doctrine. Right. So as you all can see here, when the intracranial volume goes up, at certain point, till that there will be a compensatory mechanism. I mentioned it is normal intracranial pressure is about 10 to 15. Once it exceeds the critical volume, then the intracranial pressure goes up exponentially, leading to brain herniation. At the same time, so the herniation can occur. There are a lot of herniation points, but the most importantly to us is the herniating through the foramen magnum, where it compresses the midbrain, pons and medulla, leading to compression of cardiac controlling centers and the respiratory centers, leading to death. So that is the most important thing that happened due to brain herniation. The important factor is to manage traumatic brain injury is to maintain the adequate cerebral blood flow. We call it cerebral perfusion pressure. So according to the latest guideline, it's to maintain the cerebral perfusion of 60 millimeters of mercury. As I explained before, if the intracranial pressure is critical, we say it's 20. So if we maintain the mean arterial pressure of 80, so 80 minus 60, it is 20. So that is how we calculate the cerebral perfusion pressure. So the brain has its own protective mechanism. As you all can remember during our physiology days, there's a thing called autoregulation. During the mean arterial pressure of 50 to 150, brain tries to maintain its cerebral blood flow in the constant range. Like this. Normally it's 50 ml per kilogram per 100 grams, 50 ml per 100 grams of brain during a minute. So that is the normal blood flow. But so this is the target which is given. If you are in the primary care center, if you see a patient with traumatic brain injury, according to the age, these are the targets that you have to maintain. During the first assessment, since we don't have any idea about the patient's intracranial pressure. But mind you, during the traumatic brain injury, this autoregulation can alter. Therefore, the mean arterial pressure will directly proportional. Cerebral blood flow will directly proportional to the mean arterial pressure. So if you drops the blood pressure, there won't be any protective mechanism. So brain will become hypoxic if we do not maintain adequate mean arterial pressure during our management. Apart from the blood pressure, there are certain other things that important when you are managing traumatic brain injured patient. Carbon dioxide. So as I have explained, as I have shown here, so the normal blood flow, as I mentioned, is 50 ml. So to get that, you need to maintain the carbon dioxide level of 35 to 40. As you know, carbon dioxide depending on our respiratory rate and the tidal volume. We call the minute ventilation. If patients hyperventilates, it will reduce the brain blood flow. At the same time, if patient is hypoxic, it will dramatically increase the brain blood flow. So if the brain is edematous, if we make them hypoxic, it will invariably increase the cerebral blood flow and increase the intracranial pressure. So those are the things that we need to take into account when we get a patient with traumatic brain injury. So I discuss a concept about intracranial pressure. So there are certain ways to measure intracranial pressure. In neurotrauma centers, specifically, we have these invasive methods and non-invasive methods. So this is the gold standard. In our unit, we use external ventricular drainage or EVD and microtransducer, we call ICP board. There are non-invasive method also. We use this optic nerve sheath diameter, which is measurement of optic nerve diameter using ultrasound scan. And we use transcranial Doppler also by the cardiac probe keeping on the side of the skull. And fundoscopy, which shows the fundal edema. So these things, the invasive things normally being done in the neurotrauma centers. Just to let you know about one method, this is extraventricular drainage, where we insert a small probe to patient's ventricle. So it goes to the ventricle and it connects to a system with the manometer. Likewise, so the CSF flows like this, so we can have an idea about the intracranial pressure. At the same time, there's a collecting back. If the intracranial pressure is high, CSF will come from high pressure to low pressure and get collected in this bag. At the same time, we can send samples if you are suspecting any sort of an infection. At the same time, we can give drugs through this external ventricular drainage, apart from monitoring the intracranial pressure. And this is called microtransducer, which we use to measure the intracranial pressure. So of that, we insert a small probe through the skull to the brain matter. This is the appearance it's on a patient. So it gives a value. So here is 18, I mentioned. So it's less than 20. So it's 18. So we do continuous intracranial pressure monitoring. At the same time, it gives a graphical representation of intracranial pressure, like similar to our ECG, where you know the ST elevation and ST depression. So this is the normal way. So there are three waves. So P1, P2, and P3. So if the ICP goes up, so if the brain compliance is less, here as you can see here, the P wave goes up. So then we know the patient's intracranial pressure is rising by assessing the value, and by assessing this graphical representing graph, we know the compliance is less. So there are certain things that we can do if the intracranial pressure is going up. Right. So those are the basic applied anatomy, physiology, and the measurement according to current neurotrauma management. So to start with the management of traumatic brain injury, of this case, this young chap is following accidental fall. Now he's coming to the nearest local hospital. Think about how you are going to manage this patient if you are the doctor in the local hospital. So what are we going to do? So normally the primary receiving hospital in our setup nowadays, it's quite common for us to get these ambulance service. So ultimately the management should be the normal primary trauma care management, airway with cervical spine stabilization, assessing and managing breathing, circulation, and disabilities. So patients should be transferred in a spinal board. Then you have to apply a cervical collar, because 15% of people, they get concomitant cervical spine injury with traumatic brain injury. So it's like a peripheral unit, we assume. So you can provide oxygen, you can get IV access, and you can give a 0.9% saline, and you can immediately transfer the patient to your local hospital. These are the things that we can do in our setting, as most of our unit run by the single medical officers, and you do not have, most of the time, they don't have the facilities to intubate the patient. And importantly, you have to inform the receiving center that you are sending a patient with traumatic brain injury for them to get prepared. So when you get the patient to the local hospital, you need to do the primary survey according to the Advanced Trauma Life Support Guideline, where you look for immediate life-threatening conditions. Then the secondary survey to assess and manage the potential life-threatening conditions. We'll see how it goes when you come a patient with traumatic brain injury. So as I mentioned before, you need to provide oxygen. You have to stabilize cervical spine. The target to prevent hypoxia, we target saturation more than 95. And you need to get the blood pressure according to the age. These are our targets. You can give 0.9 saline. We do not use 5% dextrose normally. We do not use albumin. We do not use other colloids like dextran, because 0.9 saline should be the choice of the fluid. And we need to monitor the pupil size, because if there's coning, there will be a pupil reactivity and pupil unequal pupils. It will alarm that patient is getting some sort of brain cornea. And we need to consider the other injuries as well. So if you are a doctor in the ETU, the emergency treatment unit, then these are the things that you need to consider if you are getting a patient with traumatic brain injury, whether you need to intubate or not. So if GCS is low, you need to intubate to prevent airway aspiration. And if GCS drops, yes, you need to intubate. Then you need to control the oxygen level, and you have to control the carbon dioxide level. As I mentioned, those two factors determine the cerebral blood flow. And the patient is getting seizures, definitely we need to intubate in terms of providing the airway soiling from aspiration. And if there is if there's any sort of bleeding, we need to protect the airway from airway soiling. So these are the indications for intubate patients with traumatic brain injury. As I mentioned before, you need to consider about the cervical spine stabilization. We have experienced sometimes patient transferred from the peripheral hospital. When they wake up following the traumatic brain injury, they can't move. They become quadriplegic because due to cervical spine injury. It's no point that saving a person being quadriplegic, even though they recovered from the cervical spine injury. And the specific things which regard to traumatic brain injury. There's a recent trial called CRASH trial. CRASH stands for Clinical Randomization of Antifibrinolytic in Severe Hemorrhage. So they have recommend to give tranexamic acid. So in your local hospital, you can give tranexamic acid 15 milligram per kilogram bolus, followed by 15 milligram per kilogram per hour infusion over 8 hours. Ideally, when the patient presents within the first 3 hours of the injury. So you can give this and you can transfer the patient. So it has been proven that it has improved the outcome following traumatic brain injury. And there's important thing when we discuss the traumatic brain injury, that is the osmotherapy. You can give either mannitol or saline. It depends on the situation. If patient is hypotensive, you are not going to give this osmotic diuretic mannitol. Then you can give 3% saline. Normally, we give 3 to 5 ml per kilogram bolus. So if a 50 kilogram person, it's like 150 ml. So you can give the bolus and you can transfer the patient. So there's no statistical significant difference between the outcome. So you can give either mannitol or saline depending on the patient's blood pressure. Right. So when you manage the primary survey and the secondary survey, once patient is stabilized, then you need to think. So if you are not in a neurosurgical center, you need to transfer. At the same time, if you have the facility to do a CT, non-contrast CT brain, you have to send the patient for a CT once you stabilize the patient. So these are the indications. If you are in a place where CT is available, these are the indications. GCS of 13 and GCS drops within 2 hours. So you need to do a CT. And there's obvious depressed skull fracture, yes. And if you are suspecting the base of skull fracture, so ENT bleeding, CSF, otorrhea, rhinorrhea, you need to do CT. And mind you, if you are suspecting base of skull fracture, you need to give antibiotics which penetrate the central nerve system. So third generation cephalosporin, ceftriaxone 2 gram BD, cefotaxime 2 gram 8 hourly or 6 hourly, ceftazidime 2 gram BD, because penicillin does not pierce the central nervous system. So if you are transferring, give the first dose, send the patient to us. And don't try to put NG tubes if patient is having base of skull fracture. But as a rule, we do not encourage to insert nasogastric tube following traumatic brain injury. So it should be orogastric tube. So if patient's having a seizure, he needs a CT. And if patient adult with more than one episode of vomiting needs CT. So these are the things. So if you get a CT, you can communicate with the neurotrauma center where you can uh, communicate and you can get their opinion regarding the further management. So if you are sending the patient to a neurotrauma center, so we have a few neurotrauma centers in the country. So most of you all working in the local hospital in the periphery, so you need to transfer the patient. So you have to stabilize the patient before the transfer. So, and you have to communicate with the receiving end. Nowadays, we use WhatsApp images to communicate with the receiving center. And as it should be done by, trained doctors. So I can remember when I was a house officer, I have transferred head injured patients without knowing these factors. So the same thing happens because the most junior doctor is transferring the patient in our setting. So it has to be done by a trained doctor because during transfer at any point patient can get deteriorate. You need to arrange the equipment and the drugs, and you need to continue the monitoring during the transfers because at any point patient can deteriorate. So you need to maintain the carbon dioxide, the saturation, and the blood pressure for the reason that we have already discussed. Once we receive the patient to a tertiary care center or a neurotrauma center, what we do is we redo the primary survey, secondary survey, including fast scan, and we reassess the drugs, whether you have the tranexamic acid, and sometimes we do repeat the CT because the deterioration can happen during the transfer itself. So when if we take the patient to the operating theater, we do a brief history and focused examination and assessing of investigation because it's a huge challenge to anesthetize a patient with traumatic brain injury. So the mainstay is to maintain the adequate cerebral perfusion pressure by the positioning and the monitoring, and we maintain the oxygenation level, carbon dioxide level, and we do not want to do further harm for the patient. So we are trying to do the neuroprotective anesthesia to maintain the remaining neurons and to recover the already injured neuron. So, right, in this operative management, so as I mentioned before, so extradural hemorrhage, what they do is the neurosurgeons, they do the craniotomy and evacuation of the extradural hematoma, which is outside the dura mater. If the subdural hematoma, which is under the dura mater, if it is compressing with midline shift, they do decompressive craniectomy. So this I have shown here, they remove this is the scalp, this is the temporalis muscle, then do a wide excision of the skull bone. So once it is removed, the brain is relaxed. As you can see here in the CT image, that here you can't see the bone. This is the bone, and here we have removed the bone. So it allows brain to expand. So it will reduce the intracranial pressure. Then the brain content do not cone because the pressure is relieved by the removal of the bone. We call it decompressive craniectomy. Then we preserve this bone flap in refrigerator, and once the patient is recovered, we do reapply that. So we call it cranioplasty. So we can replace the bone flap and close when the patient is back to normal. So depending on the patient's GCS. And there's called titanium mesh. If the bone flap is scattered following the fractures, then we can replace by a titanium mesh. That is what the surgical management. So once the surgical management is done, we try to assess the patient's GCS, and we do post-op imaging because sometimes they can get rebleeding, they can get recollection, so need to be assessed by the images. So moving to intensive care management. So there are certain guidelines worldwide accepted. So this is the Seattle International Severe Traumatic Brain Injury Consensus Guideline. This is important for the doctors who are working in intensive care units. So this is the accepted worldwide the guideline now we are using in our unit also. So critical care, it's a multidisciplinary team approach centered on patients and the family. We get nurses and we get physiotherapists, nutritionists, dietitians, everybody. So it's a multidisciplinary task. So according to the newest guideline, these are the things that we do in intensive care unit for a patient with traumatic brain injury. We do certain expected interventions and we're trying to achieve these goals. So we admit the patient to ICU and if need, we do intubate. So I will go through one by one the steps that we are going to follow. So for neuro-intensive care, we get post-operative patients and pre-op optimizations, and sometimes to measure intracranial pressure and to manage the complications such as sepsis or any other sort of bleeding or other complication. So in our neuro-intensive care or in general intensive care, which providing care for the traumatic brain injury, we have a low threshold for intubation. So as you all know, with damage to the trauma, they become agitated. At the time, they become unconscious. So to protect the airway and to maintain this oxygenation level and carbon dioxide, we are at low threshold for endotracheal intubation. Once the patient is intubated, if you do not have the facility to measure intracranial pressure, then the pupillary reflex or the pupillary reactivity is the one that we need to monitor to assess the neurology. So the size of the pupil and the equality is important. If pupils are unequal, then we are alarmed. Then we may need to do a repeat CT, or then we need to go for a surgery depending on the seating finding. So it's importantly, we need to nurse them. We need to position them in 45-degree angle in order to facilitate the venous drainage. So we have to make sure that the cervical collars are not too tight because it will hamper the venous drainage and it will increase the intracranial pressure. And like in the general ICU care, we need to provide them analgesia, we need to provide them sedation. Specific things to neurointensive care unit, we need drugs which has short half-life, which has head clearance within a limited number of hours to assess their GCS. Therefore, we commonly use propofol, remifentanil, and dexmedetomidine. But anyway, in your ICU, if you do not have this type of short-acting medication, still you can use morphine, midazolam, what is available with you. But we have to make sure that when you are assessing the GCS, since those drugs have active metabolites, you have to consider the duration of the drug when you are assessing the general GCS of this patient and the renal functions as well. In general ICUs, they normally use paracetamol and stuff as SOS basis. But when it becomes to neurotrauma ICU, we use regular dose because high temperature will increase the cerebral swelling, the brain swelling. So we need to control the temperature deliberately. So there's an entity called the central fever. If they get damage to their thalamus, they can get central fever. So we use a drug called bromocriptine, centrally acting D2 receptor agonist, and baclofen, centrally acting muscle relaxant to treat central fevers. So in intensive care also, we need to measure the adequate cerebral perfusion pressure. So if you are monitoring the intracranial pressure, then we can titrate our MAP. But anyway, we need to maintain a MAP around 80 during the initial state to provide the adequate blood flow to the injured brain. Hematologically, we need to keep hemoglobin more than 7 because hemoglobin is the one which carries oxygen to the brain. And platelet has to be more than 75,000 because they are at risk of bleeding and getting hematomas inside the brain. In general surgical wards, we accept INR up to 1.5, but in neurotrauma units, it should be less than 1.4. We have low threshold to use these dynamic clotting profiles, rotational thromboelastometry, and thromboelastograms, so that the dynamic clotting profile assessment to correct the coagulatory deficiencies, because they can get trauma-induced coagulopathy. At the same time, there are a lot of people nowadays with antiplatelet and direct oral anticoagulants like rivaroxaban, epoxybam. So we need to reverse their action if you are taking them to the operating theater. Antiplatelet, we do give adult dose of platelet, that is about 6 units of platelet. When it comes to rivaroxaban and epoxybam, the ideal reversing agent is prothrombin complex concentrate. But if you do not have, you can give FFP, the fresh frozen plasma, 15 ml per kilogram to reverse the action of direct oral anticoagulants. We deliberately maintain sodium at a higher level because the extracellular fluid, if we increase the sodium level, it will take water out of the cell. Hence, it will reduce the volume of the cells. So in general, it will reduce the cerebral edema. So that is the normal intensive care management. But when it's specified to a place where you are monitoring the intracranial pressure, like in neurotrauma unit, so you need to follow this escalation guideline. That is, if you are unable to maintain intracranial pressure less than 22, you would escalate your treatment likewise. So you will increase the analgesia. You will bit of a hyperventilation. As I mentioned before, carbon dioxide level is 35 to 40, but you do bit of a hyperventilation to reduce the cerebral blood flow. You give mannitol boluses and hypertonic saline. And if you have the facilities, normally we have in neurotrauma centers, we do insert EVD and divert the cerebral spinal fluid out of the brain to reduce the cerebral edema. And we do start anti-seizure prophylaxis. In the peripheral hospital, if you get a patient following traumatic brain injury fitting, you can give a loading dose of anti-epileptic. Nowadays, it's more towards levetiracetam, but if you do not have, you can give phenytoin. If you have levetiracetam, that is the most safer drug. So in intensive care, if the ICP is going up, we escalate our management to a higher level. We call it tier 1. The same thing we did at tier 0 level, we escalate. So if you are unable to maintain the intracranial pressure, even with our escalated management in tier 1, we need to escalate our management to tier 2. So then we are trying to maintain the intracranial pressure. So we do neuromuscular paralysis. But in practical setup, if you are transferring the patient from your local hospital to a neurotrauma center, better to paralyze the patient, because in between, during the transfer, they might become agitated. Therefore, better to paralyze and transfer. But in the intensive care unit, we paralyze them only if you are unable to maintain the intracranial pressure. So here at this level, we do paralyze and we'll try to maintain the mean arterial pressure and to reduce the intracranial pressure. So if you fail to maintain intracranial pressure less than 22 with all our management, we call it refractory intracranial pressure rise. Then we need to go for surgery. We call it secondary decompressive craniectomy. The first one we did, it's a primary decompressive craniectomy. Patient comes, we do the CT, there's an indication for surgery, we decompress the primary decompressive craniectomy. If you are not doing primary decompressive craniectomy, we manage them in the intensive care unit. And we try to manage medically, as I explained, by monitoring the intracranial pressure. If you fail to maintain the intracranial pressure less than 22 millimeters of mercury, then we need to do the secondary decompressive craniectomy. There are certain other things that explain in the guideline, that is the phenobarbital coma and hypothermia, but it's not much evidence to support them. So in our unit, we go for secondary decompressive craniectomy. So in general, in the newest guideline, there are certain things that they de-emphasize. So still we see some patients with dexamethasone following traumatic brain injury. It is contraindicated. Decades back, it was done to reduce the cerebral edema, but current evidence, according to level 1 evidence, it is contraindicated. So you are not supposed to give dexamethasone for patients with traumatic brain injury. So rest of the ICU management, we prevent DVT prophylaxis, because we give DVT prophylaxis because DVT is the third leading cause of death following traumatic brain injury. In your unit, you can start pneumatic calf compression stockings, DVT stockings, and pharmacological things we do consider a bit later because the risk of bleeding. And we need to provide nutrition. I'm sure you all have the medical officers nutrition. They will support you because they are in the catabolic state. So we need to provide nutrition to improve their recovery. Then there's an important thing we call neuro rehabilitation. So it is an integral part of managing traumatic brain injury, because when we recover them, so we need to rehabilitate them because they are handicapped, they have weaknesses, and not like the other injuries, the brain takes time to recover. So not only the brain, so their limbs, we need to prevent critical illness myopathy, we need to improve their function. So it's a multidisciplinary team approach with the rehabilitation consultant to start them to send back to the society as productive people. We do start it during the ICU stay itself, and we'll continue to the HDU and the ward when we step down there. It's the other thing, if the brain is unsalvageable, so we can't do anything. The only thing we can do to harvest their organs and to provide to a person who is suffering from end organ failure. So far we have, so this is our last year statistics. So this is again an integral part of managing traumatic brain injury. If we can't survive, we are trying to survive the people who needs their organ support. And so sometimes if brain is unsalvageable, if patient became vegetative following the trauma, if it is not the best interest of the patient to prolong his agony, if we do not see a recovery, so with the discussion of the family and the neurosurgical team, we do send them over through the end of life care pathway. We keep them comfortable until they die. So the summary. So traumatic brain injury is a critical public and socio-economic problem. As I mentioned, all the breadwinners are affected. So it's going to be a huge socio-economic problem, especially a country like Sri Lanka. So your initial management is important. So it all depends on the outcome, depends on the initial management. So you will, it depends. So you will determine whether the patient is going to go back to the society as a productive person, or whether he's going to confine to a bed, or whether he's going to confine to a wheelchair, or whether he's going to become permanently vegetative rest of his life. So it all depends on your management, initial management, and subsequent management. So it's a national responsibility, I think, for all of the doctors to manage them at the initial stage. It will definitely improve the outcome. So we discussed the surgical as well as the medical management. It's always a multidisciplinary team approach. So including lot of people, nursing officers, healthcare assistant, physiotherapists, respiratory therapists, and all the other managing staff. And the neuro rehabilitation is very much important because not like the other injuries. So not like after doing a laparotomy, you can extubate, you can send him back to the ward. But it's not like that. They stay longer. So normally we get about 25 to 30 admissions to our ICUs per week. So when for the month, it's like for a week. So when you for a month, it's like 100. So it's like 1,200 per year. So it's very much difficult and it's challenging to provide intensive care beds and managing them because they do stay longer in contrast to other intensive care patients. And they become handicapped. So therefore, to get them to the maximum level of mobility and their functional status, we need to do rehabilitation. And mind you, we need to transfer back them to you because we are getting huge number of admissions to cope up these numbers. So we can't allow a single patient to die on the road by telling that we don't have beds. Therefore, it's a huge challenge to rotate the bed number. Therefore, we might send them back to you for neuro rehabilitation. So it's your duty to continue the neuro rehabilitation and continue the other supportive care which can be provided in your unit. So I think that is end of my talk. So if you have any problems or queries, you can email me and call me if you need any sort of help or any assistance if you think that if you need when you encounter with a patient with traumatic brain injury. Thank you.
Thank you, Dr. Eranda Sanjeeva, acting consultant intensivist, for that informative lecture. And we have received numerous questions via the registration form and chat box as well. Most of the questions were answered during the session. And unfortunately, we have a limited time period. So we are going to address as many questions as time allows during this session. And also, we are delighted to see that there were more than 500 doctors logged in, but unfortunately, it exceeded our capacity. So the first question I'm going to ask how to differentiate traumatic brain injury with strokes.
Need to follow our basic management. So in the history, so in the traumatic brain injury, you will get a history that a trauma. If you found unconscious, then it's a bit of a difficult. So stroke normally, the major cause is hypertension. So the appearance in the CT, so the history, they will get sort of a history of hypertension. And when they admit to the hospital, again, they will record a higher blood pressure. So the history. In the examination, they might see the weakness and all according to the neurological examination. When it comes to investigation, there's a certain pattern of appearance in hypertensive bleeding in CT in contrast to the traumatic subarachnoid hemorrhage or traumatic intracerebral hematoma. Those are the way that we try the way that we think that we can differentiate traumatic intracerebral hemorrhage in with the non-traumatic stroke. Stroke could be hemorrhagic or infarction. So the difference with the hemorrhage, if there's a bleeding, only we need to differentiate it with the trauma settings because the infarction, it's most of the time due to non-trauma.
Next question is active cooling recommended in traumatic brain injury?
It is mentioned in the guideline, but nowadays it is not recommended. Evidence does not support for active cooling because one thing, you need to have the equipment to make them active, cool them, they reduce their temperature. But when you reduce the temperature, it will cut off your coagulatory factors, coagulatory ability by 30%. Then you might bleed. Number two, it will reduce your immunity. So you are prone to get infections. And the enzyme function, we know it's dependent on the temperature. Therefore, there are a lot of adverse effects when you do active cooling. Therefore, it's not recommended. Nowadays, we do not do in Sri Lanka, but in other countries, they do not promote active cooling for a patient with traumatic brain injury.
And also, there is a question. I think these questions are from the doctors in peripheries. If patient is under the influence of alcohol and having TBI, how do we assess the GCS and identify need of intubation?
Good question. So it's difficult. So if patient is under influence of alcohol, you can't you can correctly assess the GCS. Then it's depend on the clinical assessment. If you think, for an example, if patient is agitated, if it is struggling, then you, for the safety of the patient, you can electively intubate. That is what we recommend. Even in our ICUs, sometimes we get drug addicts, alcoholics, they agitate, they struggle, then it will lead to raise their intracranial pressure. Then for the patient's safety, in spite of the other factors, we do electively intubate. Then we can control their oxygen level, their carbon dioxide level, their blood pressure. Then we treat them, we detoxify them. Then when we assess them, then we gradually extubate them. We wean off and extubate them once this intoxication part is over. So if you are in the periphery, if you are struggling, better to intubate in terms for the patient's safety and the staff safety also.
Okay, what's the place in creating burr holes before transferring patients of EDH?
Actually, there was a time it was recommended, but nowadays it is not being done. So even with the extradural hemorrhage, it depends on the surgeon. So some people who are trained and who are having the capability, they do evacuate, but when it's difficult to transfer because they might bleed during the transfer. So the current the management in our country, they do not do burr hole evacuation. They straight away send to us, to the neurotrauma center.
There's another question. How to manage CSF otorrhea or rhinorrhea following traumatic brain injury?
So the immediate management, you have to keep them at 30-degree head position. And if there's a continuous otorrhea, you need to pack. Even with the continuous rhinorrhea, you need to pack with sterile gauze. Then you need to give antibiotics, which has the ability to penetrate the central nervous system. As I mentioned before, third generation cephalosporin, cefotaxime, ceftriaxone, ceftazidime. And there is a place for the immediate management. But subsequently, later you can start, there's a drug called acetosolamide. We call it Dimox, which reduces the production of CSF. Dimox, acetosolamide. So you can start that drug also. But subsequently, you need to refer for the ENT team, because if there's a continuous team, they have a certain set of investigations to see where the place. If they can't find the place, they can do the dural repair. Or with the drug, it can cause metabolic acidosis. So if you are starting Dimox or acetosolamide, you need to monitor blood gases because they can go into metabolic acidosis.
What is the latest guideline to use in Sri Lanka for management of TBI?
So currently we are using this CB guideline, Seattle International Brain Conference, the guideline conference guidelines, and the Brain Trauma Foundation guideline. It was 2016. There was some amendment in 2024. So it's basically a unit protocol. So there are certain guidelines. So you rectify, you collect it, and you prepare it according to the facilities you have in your particular unit. So if you can read, that is the CBIC guideline, is the most recent guideline that worldwide used in a lot of neurotrauma centers in Sri Lanka as well as in the UK.
What are the features to identify early deterioration of patients?
Well, it is, I would say, the GCS, if patient is conscious. So patient comes with GCS of 15, then it slowly drops. So then patient is deteriorating. And the pupillary examination. So unequal pupils is alarming. And the other things like the conscious level, as I mentioned, by assessing by the GCS. So by head injury itself, it is difficult for them to drop the blood pressure because the brain is quite small cavity. So bleeding into the brain does not cause hypotension. So if there's a hypotension in a patient with traumatic brain injury, you need to exclude spinal cord injury, because when the sympathectomy happen due to neurogenic shock, there will be a hypotension and bradycardia. And you have to exclude the other causes of bleeding, abdomen, lower limbs, chest, then other things has to be excluded.
I selected this question as the last question. When are you all planning to do a workshop recently about traumatic brain injury?
Good question. At the moment, there are certain workshops conducting. One is NTMC, National Trauma Management Course, which is conducted by College of Surgeons. And there are other like ATLS and per se from our unit. At the moment, we recently conducted few courses, but as per College of Critical Care Physicians, we would have our sessions in August. So there may be a workshop related to traumatic brain injury, which will be published in our website. If you are really keen, and just email your details. When there is a workshop, I will let you know for sure.
Okay. Thank you very much, Dr. Eranda Sanjeeva, for your informative presentation on management of traumatic brain injury. And we were very happy to see that there were more than 500 doctors participated in this webinar program. And your expertise has definitely provided all of us with a good understanding of how we should manage the patient with traumatic brain injury. Your dedication to sharing your knowledge with us is greatly appreciated. To all our participants, thank you for joining today's free program. As mentioned earlier, the link for feedback and post-assessment questions is now available in the chat box. Kindly take a few minutes to provide your feedback and complete the post-assessment to receive your e-certificate within the coming week. Otherwise, you will not be eligible to have the CPD certificate. The Shri program will continue next Sunday as well with another relevant clinical topic. We warmly invite you to join us once again for another productive session. Thank you. Thank you, Dr. Sanjeeva, for your time and for sharing your expertise. And thank you to all the doctors who participated today. We look forward to seeing you again next Sunday morning. Thank you and have a nice day.
Thank you.